Good morning, good afternoon, good evening, everybody. My name is Satvika Chalasani, and I work at the United Nations Population Fund based in the Technical Division in New York, where I focus on adolescent and youth sexual reproductive health and rights, including child marriage. Today, I'm going to be speaking about the very first paper in the supplement that we did in the Journal of Adolescent Health with WHO to mark 25 years since the landmark ICPD conference. The paper is titled The State of Adolescent Sexual and Reproductive Health. It was co-authored with many wonderful colleagues from UNFPA as well as WHO. The aim of the paper was to do a sort of stock taking, and it provides an overview of the levels and trends in a wide range of indicators related to adolescent sexual reproductive health and rights and how they've evolved since 1994. So when we looked at all the data and we put it together, for our own understanding, we classified it into three broad areas. The first was on the new demographic realities that adolescents are facing and they themselves are part of. What do we mean by that? The first is that there's more adolescents today than there were 25 years ago, 163 million more to be precise. But within that, there's actually more boys and young men than there are girls and young women. And part of the explanation for that lies in the practice of gender-biased sex selection in some regions and excess female mortality. We also saw that adolescents are now growing up in smaller households. And that's, of course, driven by declines in total fertility rates across regions, but with, of course, variations between countries and even within countries. The final point on the demographic realities that's important for us to know is that adolescents are growing up in a time of increased longevity, life expectancy that is, as well as health. And so adolescents themselves can expect to live longer. So the second broad area for us to understand how things have evolved over time was by looking at the changing burden of illness. The Lancet Commission on Adolescent Health and Well-Being looked into this recently, and you can see a link to their article on the slide over there. And they classified countries into three categories. The first was what they called the multiple burden countries. So those have communicable diseases, SRH-related negative outcomes, as well as nutrition-related negative outcomes. In addition, they also have excessive injuries, and they have non-communicable diseases. Then are the second two categories of countries, which are either injury excess countries or non-communicable disease dominant countries. But what has happened in the past 25 years is that more countries now have this multiple burden in that first category. And part of that is driven by, for example, there's anemia, which is still widely present, but there's also been an increase in the prevalence of overweight and obesity, which of course has implications for sexual and reproductive health. The final broad category of factors in relation to adolescent sexual reproductive health and rights that we looked at was on the social context. And what we mean by that, very first, is that adolescents are growing up in an increasingly urban environment. So more adolescents now are living in urban areas than before. And with that, there's a whole host of related factors. The first being that they're more likely to be digitally connected, while recognizing unevenness in access to digital technologies based on age, gender, ethnicity, etc. We do know that on average, adolescents are more likely to be digitally connected today than before. They're also more likely to be enrolled in school and to complete school. Of course, most of the progress has been at the primary level, but there's also been gains in secondary level education for males and females. They're also growing up in the context of declining poverty. So overall worldwide poverty has declined fairly dramatically over the past 25 years. But we know, of course, that inequities persist and there are still large populations still living below poverty lines. And that's related to areas where there has not been much progress. So the rates of unemployment and underemployment for young people are higher than those in adults, and there are growing sex disparities between young women and young men on that. The rates of working poverty have also increased. So young people are working, but they're still living in poverty. And this is saying something about standards of living, quality of life, wages, the type of work that they're able to be engaged in. So after we looked at the context, so the changing social context, the demographic realities, the burden of illness, we looked at the indicators themselves in ASRH, and what we see is progress in some areas but not in others. So to start with, boys and girls are initiating sex at later ages than they did before. So age at first sexual intercourse has gone up. Girls are less likely to be married and less likely to be pregnant before the age of 18. They're also more likely to use contraception and maternal health care when they do get pregnant. Girls are less likely to support and experience female genital mutilation, which together with child marriage is seen as a harmful practice. Boys and girls are also less likely to have sex with a non-marital or non-cohabiting partner and are more likely to use condoms. Which brings me to HIV, whose incidence is actually declining slowly, but deaths in adolescents due to HIV are not declining. STIs globally, the levels are high and they're actually increasing, but the data on this is fairly limited. Levels of intimate partner violence are also high. My final point is on abortion. There are no clear trends on unsafe abortion and mortality and morbidity resulting from it due to heavy data restrictions and in general a reluctance to discuss this issue more openly. So the last section of the paper looks at gaps and emerging areas. Overall, what we see is that despite progress, it has been uneven and inequalities persist. So countries and regions that had high levels and burdens of poor SRH outcomes for adolescents continue to lag behind and have challenges. For example, Sub-Saharan Africa, but also Latin America and the Caribbean, where you see, for example, high levels of adolescent pregnancy among indigenous girls, among girls from poorer families. It will be critical to track and tackle the rise in STIs, as well as the small but notable rise that we saw in reproductive cancers, because countries are not necessarily equipped to deal with that disease profile. We also need to understand better the interaction between what's happening on adolescent overweight and obesity and its consequences for sexual and reproductive health. Menstrual health, which has been traditionally somewhat of a neglected area, is now getting renewed attention. Knowledge levels among girls tend to be still quite low, and stigma tends to be high. So comprehensive sexuality education provides a good entry point to addressing and tackling some of that. Finally, what we see overall is more of a focus on physical health and less on mental health and social well-being. What we see largely in the field of adolescent sexual reproductive health is a disease-centric risk reduction approach and less on a holistic approach. To conclude, I would like to say that although adolescence in general is a vulnerable period, characteristics of specific subgroups of adolescents intersect to heighten their vulnerability. So in particular, adolescents of diverse sexual orientation and gender identity, adolescents in humanitarian contexts, and child or adolescent-headed households are under-researched groups. But we do know that these circumstances matter for adolescent SRHR. We just need to understand them better and know what to do about it. So that concludes my presentation. I hope you found this first paper useful.